This is week 7, instructor recording in quality management in healthcare. This lecture is on report cards and dashboard reports. In this session, we have learned about quality management theory, process, measurement, and now we need to understand how we can report our outcomes and how the industry is starting to report outcomes. So as we begin, we'll see that one of the major ways is through healthcare report cards. A report card is an annual report on the quality and outcome of care by a particular healthcare provider or healthcare facility, such as a hospital. It also provides information on aspects of healthcare which is provided to the public to help consumers choose their health plans or their physicians. It provides information that includes patient outcomes, satisfaction, cost structures, or the plan's healthcare delivery. Healthcare report cards are based on a data to decision cycle. This means that the TQM process enables us to collect data. We've seen that in some of our previous sessions, that by going through the PDCA or one of the other TQM theories or processes, we end up collecting data. And this data then is transformed into information. And if we do it right, the information becomes new knowledge about the process or the procedure or the policy, whatever we're happen to be looking at. And then this knowledge supports decisions and actions for improving our performance as providers. And all of this then relies on a standard of measurement. In other words, we can't be comparing apples and oranges and grapes. We need to make sure that we are comparing apples to apples, oranges to oranges, etc. So over the course of a few years, there are several types of report cards that are being used. One is process report cards. A second one are survey report cards, or report cards based on surveys. And the third one is outcome report cards. So let's just review each one of these types. A process report card is one that describes the inputs that a physician, hospital, or health plan uses in treating patients. So some examples of this is the percent of women aged 52 to 69 who receive a mammogram within the past 2 years. That is measuring a process, the process of receiving a mammogram. And then there's a time frame within the past 2 years. A second example of a process report card is looking at the number of nursing staff hours per resident per day in a nursing home environment. And a third example is the use of a computerized medication ordering or prescribing system that automatically checks for drug interactions and dosage errors. So that you can see that each one of these examples includes looking at a process, collecting data related to that process, and then putting it into a report card format so it can be evaluated. A second type of report card is that of a survey report card. It presents patients' subjective evaluations of quality of care and/or customer service. So some examples of this is, for instance, asking the patient, on a scale of 1 to 5, did your doctor and/or hospital staff respect your preferences in the course of your hospital stay? The second type of survey question might be something like, did your doctor and/or hospital employees adequately treat the pain you experienced during your stay? So you can see that there can be a series of questions that are put into a survey format and asked either at the end, upon discharge of a patient in a hospital, and/or it can be a letter and a hard copy survey that are sent to patients maybe a week after discharge. Or in this day and age, it could be something that's put into a Survey Monkey type of a format and done for the computer. And the third type of report card is that of an outcomes report card. This one presents average levels of adverse health outcomes, such as mortality or complication rates, experienced by patients in a plan, such as a health plan, or who are treated by a doctor or a hospital. So examples of this is the percent of patients receiving cardiac bypass graft surgery who die within 90 days of the surgery. So they're looking at the number of patients who don't recover and who actually pass away 90 days after they've had the surgery. Another example is the percent of patients in a nursing home who develop bed sores. And this can be something that's looked at outcomes because you're looking at a treatment modality such as surgery or treating bed sores and then measuring at certain points. In the case of the surgery, it's 90 days post-op. In the case of bed sores, it could be an evaluation and a data collection at 2 weeks, 4 weeks, 6 weeks, and see if the treatment that's being provided to that patient with bed sores is actually helping the patient clear up those bed sores. So you're looking at the outcome of an intervention or a behavior. So those are the three types of report cards that now are commonly seen in the healthcare industry. The concept of hospital report cards gained a lot of momentum when the magazine U.S. News and World Report developed and published its hospital honor roll. And a place on the Best Hospitals honor roll is reserved for medical centers that demonstrate unusually high expertise across multiple specialties, scoring at or near the top in at least 6 of the 16 specialties. And it's interesting that in 2011 and 12 rankings that only 17 of the nearly 5,000 hospitals that were evaluated actually ranked high. So they ended up on the honor roll. So hospitals with the highest scores in a given specialty received 2 honor roll points. Those with slightly lower scores received 1 point. And the honor roll standing was determined by the total number of points, honor roll points, across all 16 specialties. So you can imagine the scurrying of hospitals to find out where they stood, first of all, if they made the honor roll, and then secondly, if they were listed on the honor roll, which ranking they received. So in the hospital rankings for that year, you can see that Johns Hopkins Hospital in Baltimore got 30 points within 15 specialties. Mass General in Boston got 29 points for 15 specialties. Mayo Clinic got 28 for 15 specialties. Cleveland Clinic, which was number 4 on the list, had 26 points for 13 of the specialties. Ronald Reagan UCLA Medical Center here in California got 25 points out of 14 specialties. New York Press in Cornell got 22 points for 12 specialties. Number 7 is UCSF Medical Center in San Francisco, which received 20 honor roll points for the 11 specialties out of the 16. And Brigham and Women's Hospital in Boston, 18 honor roll points. Duke University, which is now we're at number 9 on the honor roll in North Carolina, got 18 honor roll points for 10 specialties. And then number 10 on their honor roll for the U.S. World and News Report was the Hospital of the University of Pennsylvania in Philadelphia, which got 17 honor roll points for 12 specialties. So this was just an example of how all of a sudden this data that had been collected is being used to report out hospital standings with these standardized rankings. And as I said, it was quite a shock to some of the hospitals, and now they work very hard to be on these lists, to be on this honor roll, because they understand that the consumers are now starting to compare one hospital against another one and making decisions about where they will go based upon that information. Another type of report card has been developed by a group called the Leapfrog Group, and they developed a survey type of report card that's based on and looks at patient safety. This survey, which was launched in 2001, focuses on 4 critical areas of patient safety: the use of computer physician order entry, the acronym is CPOE, to prevent medication errors. We've talked a little bit about that in some of our other discussions, is that many hospitals are now starting to look at computer order entry because there's built-in standards that prevent overdosing and the wrong med being given and allergic reactions and those types of things. So that was one of the Leapfrog Group's patient safety areas. Another one is looking at standards for doing high-risk procedures such as heart surgery. Third one is protocols and policies to reduce medical errors and other safe practices recommended by a group called the National Quality Forum. And then the last one, looking at patient safety, was adequate nurse and physician staffing ratios. In addition, in the Leapfrog Group Patient Safety Survey, hospitals are measured on their progress in preventing infections and other hospital-acquired conditions, and for adopting policies on the handling of serious medical errors, among other things. So the Leapfrog Group brought another type of report card looking at patient safety and using the survey as their measurement tool. And just looking at, you can go online and look up the Leapfrog Group and find their most recent. But in 2010, the Leapfrog top hospitals included the Mayo Clinic and Pacific Medical Center, the Davies campus in California, several Kaiser facilities: Riverside Medical Center, Antioch Medical Center, Fontana, Harbor City, Kaiser Permanente Los Angeles, and the list goes on, because Kaiser has implemented very high standards for patient care and patient outcomes. So the top, many of them are Kaiser facilities. But then you also have Mills Peninsula Health Services, Stanford Hospital and Clinics, and the University of California Davis Medical Center. So all of those are California top ranking, Leapfrog ranking hospitals as of 2010. So as a consumer, you can go now and start looking at all of these different types of report cards and reporting mechanisms just by Googling Leapfrog Group or standardized U.S. World and News Report and those types of things, or just healthcare report cards. You'd get some interesting information. There have also been report cards developed specifically for consumers. One is a consumer checkbook type of format that considers that roughly 1 out of 10 Americans will be admitted to a hospital within the next year. And a key question for anyone who's entering the hospital now is, how do you assure that it's a good hospital? How do you know that their patient safety standards are up to par, that their OR standards are up to the standard of practice in the community, that the administration and physicians and nurses are all looking at measuring patient outcomes? So the Consumer's Guide to Hospitals provides an excellent starting point for looking at this information by providing a comparison of death and adverse outcome rates for over 20 types of procedures and diagnoses. It also includes a report showing how doctors rate the hospitals, and this is available for over 1,300 acute care hospitals, so that you can go in and see how physicians who use that hospital rate the hospital that they're using. And these are in such areas such as low-risk adult surgery, high-risk adult surgery, complex medical care for adults, and the list goes on and on, for over 1,300 acute care hospitals throughout the country. The consumer checkbook also includes a detailed report on each hospital with key facts bearing on the quality of care. So there again, starting to look at measuring patient outcomes and comparing those between hospitals and between acute care environments so that the consumer can go in and actually make some informed decisions about where they want to have their surgery or where they want to have their diabetes cared for or where they want to send their mother for care. So all of this information now is becoming much more readily available since the concept of these healthcare report cards has come about. Another consumer website is called Health Grades Incorporated, and it is the leading independent healthcare rating organization, so Health Grades Incorporated. It provides reports and ratings to guide you, the consumer, to seek out better care providers. And its database includes 750,000 physicians, so it gives you ratings on over 750,000 physicians, 5,000 hospitals, and 181,865 dentists. So almost 182,000 dentists are in this database. So you can imagine how extensive that is and how much data has been collected. So just as an example, if you go to Health Grades Incorporated and you look up Hoag Presbyterian Hospital in Newport Beach, which is known as a very good hospital. It's got a good reputation here in Southern California. But you can see that it's not perfect. The slide didn't come through very well, so I'm going to kind of clarify that each patient safety indicator is rated independently, and some indicators apply to more than one patient. Some patient safety events occur more frequently than others. So you can see that that Hoag Presbyterian in Newport Beach has a pretty good rating. They actually ended up with 6 within the average rating category. 5 were within the better rating category, and they only had 1 that actually fell in the worst category. And just to define each one of those, if you got a point or points in the better category, it means that fewer patients were affected by that outcome than expected. If you rated in the average category, it means that about the same number of patients were affected as would be expected in that category or in that criteria, the indicator. And if you got a worse rating, then it meant that more patients in that patient safety indicator were affected than expected. So these were then based upon standardized rating categories. So some of the patient safety indicators were, the first one is death in procedures where mortality is usually very low. And Hoag got an average rating. So they had a few more deaths than were to be expected for procedures that usually had a very low death rate. Pressure sores or bed sores that were acquired in the hospital, Hoag rated better than most. Death following a serious complication after surgery, Hoag was average. The indicator of a collapsed lung due to a procedure or surgery in or around the chest, Hoag rated better in that category. And then the only one that Hoag rated worse was catheter-related bloodstream infections acquired at the hospital. So this goes back to that checklist that we talked about in one of our previous sessions about central line infections and how high of a negative outcome that is for patients with central lines, that the infection rates are very high. So maybe Hoag doesn't have a checklist for insertion like the physician who developed it at Johns Hopkins and saw those tremendous turnaround in negative patient outcomes. So you can see that there are other ratings that were presented by Health Grades Incorporated. This is a consumer site, so anybody, you, me, or anybody, can go into Health Grades, put in a hospital, and look at our nearest community hospital or the hospital that you would be taken to in an emergency or for an elective admit. and you can see how that hospital rates related to these patient safety indicators. So it's really very good information that's now available to the consumer. Report cards and information became an issue, though, as more and more of these entities started publishing all of this data, had access to medical records and patient data and outcomes, that in 1996, the HIPAA law was passed, which stands for Healthcare Insurance Portability and Accountability Act, so HIPAA, H-I-P-A-A, which was mandated by Congress to establish a methodology for instituting a national unique patient identifier system. In other words, there were some issues related to people's information being shared, data being collected without their unique identification being protected. So in other words, all of us that are admitted to a hospital, we don't necessarily want our information being transported through computers or through surveys or any of these kind of measurement activities. We don't want our information with our name and all of our other privacy information shared with others without our permission. So HIPAA is a huge, huge law that has come about, and there are major fines. I mean, thousands and thousands of dollars in fines if a hospital or a healthcare system or a physician's office is found guilty of sharing patient information that can identify that specific patient. So efforts blocked by consumer debate and political pressure started to question the invasion of privacy, that all of this data sharing, report cards, being out on the internet. So there's now, since 1996, there's been some very strict rules, regulations, and policies for those people handling patient data that they need to abide by. So that's a good thing. And you might have noticed in your own physician's office where we used to just go in and maybe sign in on a big checklist that we arrived and this was our home address and our phone. Has anything changed? Now you'll see in a lot of physicians' offices, because of HIPAA rules, that you sign on a place and then that information is on a sticker tab and it's pulled off by the receptionist. That prevents the next patient from coming in to see all of your privacy information. So even very small and independent physician officers are being held to HIPAA rules and regulations. And, they don't want some anonymous person coming in and reporting them to the federal government because of HIPAA violations, because, as I said, it can be thousands and thousands of dollars worth of fines. So let's consider the pros and cons of hospital report cards. Some of the pros are that it provides information to the consumer. So all of these efforts to get data, to report it, to compare it in an apples to apples format so the average consumer can understand it, can be a positive thing. It also, or hospital report cards also motivates hospitals and doctors to monitor their own performance. I gave the example of a physician office and one patient not wanting to read all the privacy information about another patient. It's also an incentive to promote total quality management and quality improvements based upon the findings. So based upon the TQM process and the data that's collected, then this is an incentive to promote change and improvements. So that's a pro to this type of hospital reporting. Some of the cons, however, is that there's a lack of standardized measures to compare. So you may have one hospital in California collecting patient safety data based upon a certain set of indicators, but there may be another hospital in Texas that has developed a totally different set of patient safety indicators. So when you go in and try to compare those two hospitals, that's when you're comparing apples and oranges. So there's some efforts throughout the country to try to standardize some of these indicators across at least the United States, and then even sometimes across other countries. Another con is that it may promote more focus on quote unquote getting good grades than on really the quality of patient care. We're going to see an example of that in a minute. It also may encourage providers to quote game the system unquote by seeking healthier patients and avoiding sick ones or both, so that by having this data collected and physicians knowing that, providers knowing that this data is being collected, they may actually refuse to take a more serious patient because they don't want it to look bad on their report card. So you've always got ways that, humans, people want to be successful and want to look successful to others. And they also want to compete for patients, for reimbursement. So that's one of the cons that's been illustrated with report cards and data collection, is that people are finding ways to get around the system. So that's really kind of a discussion about hospital-based report cards. But I also wanted to mention that there also now have been developed community health report cards. So it's not just acute care that's being evaluated and reported on. There's a lot of effort to look at ambulatory care and community health environments and looking at data collection for community health. Because as we all know, the real focus of preventative care is to keep patients out of the hospital, to keep them out of acute care environments, and to do more work out in the community in clinics and healthcare centers and all the other types of school-based programs that some of the health plans and insurance companies are rapidly developing. So community health report cards encourage continuous improvement in performance versus just looking at specific measures in performance. So looking at overall practice and outcomes versus just one or two things independently. They also motivate performance improvement through benchmarking and comparison with peers, very similar to the work that's been done in hospital report cards. It enables, or they enable, aggregate measures of performance across groups, such as health plans, so that health plans now can look at data across all of the health plans and do some comparisons of their performance. And consumers can go in and look at the outcome measures and the performance measures with Blue Cross versus UniHealth versus Kaiser. So it really does give more individuals, more information to individuals and or communities that have started using these standardized measures. And then community health report cards also create a framework for identifying best practices among those under the studies. So that's where we start looking at evidence-based practice, even out in the ambulatory care settings. So the rationale for report cards in community health also includes that they rely more on coordination and cooperation versus competing with each other. So they're looking at really trying to coordinate patient care among a group of agencies versus each one just doing the same thing. So for instance, you take a group of community clinics in a city or in a county, and instead of having patients kind of play the system and go to each clinic for their care to try to get more care or better care, now what's being looked at is being able to work in a collaborative fashion to coordinate the care of a patient. So you might have one clinic that is develops an expertise in diabetic care. You have another clinic that develops an expertise in cardiac care, so that those clinics then coordinate patient care amongst themselves. So it decreases the cost of care for a community. They also develop tools for collaboration and interagency cooperation focused on health improvement. So health improvement for a population that's receiving that care. Community health report cards also help to identify gaps in care services within a community. So if you've got all of these agencies now coming together, sitting at the same table, comparing their data and their outcome measurements for patient care, Then they're going to find out that, oops, we've got diabetic care covered, we've got cardiac care covered, but gee, nobody's doing colonoscopies as a screening mechanism for colorectal cancer. So there's no place for patients to go for that service. So that then allows a clinic that's out there that hasn't developed a specialty to maybe jump on board and develop that specialty. So you're able to provide a continuum of care for patients within a community or a county or a city. And then community report cards can also provide a framework for performance standards and measurement among these agencies, so that you see now that there's care coordination coming together to collaborate on the provision of care. And that we've talked about before, that's very important as we move forward to implement the Affordable Care Act, that there's thousands of dollars being allocated, millions of dollars, in fact, being allocated to be given through grants to cities and communities that develop collaboration, so collaborative efforts to look at care coordination for these new people that are now going to be eligible for health benefits through the exchanges. But what they don't want to happen is that there's duplication of services. So part of the requirements for getting this millions of dollars coming into counties and cities is that there is a collaborative effort for outreach and education. Some of the criticisms of standardized reporting systems are the same ones we hear about, high school or, school-based report cards, is that they can fail to account for the uniqueness of the agencies and local administrations. So just like in a school system, you always hear students or parents saying, but you're not looking at the uniqueness of my child within the system, or you're not looking at the uniqueness of the private school that my child goes to when you're trying to compare all of the schools within a county or a city. So it's the same thing with standardized healthcare reporting systems, is that it's hard to account for these independent uniqueness of agencies and hospitals or ambulatory care services. However, there is research in progress, ongoing research to identify a core set of community health indicators. So there's lots of people out there working on looking at trying to identify a core set of indicators that will be acceptable to all of these agencies. And one such effort is that of the Institute of Medicine, that in 1997 proposed 25 indicators that kind of provided a starting point for standardizing measures. And some of these measures are things that you've heard about, such as Healthy People 2010. That was really a big thing when those indicators, those standard indicators were published, and everybody started looking at Healthy People 2010. Now we've got Healthy People 2020, so that those are the things that we can use as standardized indicators to be able to measure and compare apples to apples within a setting. Another effort to standardize measures has been developed by the Institute for Healthcare Improvement, and that's called the IHI. And the Institute for Healthcare Improvement believes that new designs can and must be developed to simultaneously accomplish three critical objectives. And these three critical objectives have now known as the triple aim. And you're going to hear this over and over, the triple aim. And the triple aim includes improving the health of the population. Number two is enhancing the patient experience of care, which includes quality, access, and reliability. And the third of the triple aim is to reduce or at least control the per capita cost of care. So improve health, enhance the patient experience, and reduce cost per capita. So starting in October of 2007, the IHI began working with a group of 15 organizations in the United States, England, and Sweden that are committed to implementing the 5 design components of the triple aim. Currently, this program has expanded to over 50 organizations from the United States, Canada, England, Scotland, Sweden, Australia, New Zealand, and Singapore. So you can see how this concept, and very simple to identify these three aims to improve health of the population, patient experience, and control costs, that now there are many, many organizations across the world that are starting to look at measuring information, measuring outcomes, and collecting data so that it can be compared outside of just the United States. So this data, as it's now starting to come out, has become very valuable to advance the thought of evidence-based practice, to advance patient safety, to look at decreasing all of those errors that we've heard about within healthcare, the 98,000 medical errors in the United States that we have to address. But the bottom line still is, are report cards good for patients? And one example was a study published in the Journal of Political Economy in 2003 that looked at CABG procedures, which is a heart procedure. And this study used Medicare claim data on elderly patients and U.S. hospital characteristics from the American Heart Association to analyze the impact of report cards at both the patient and hospital level. So it was a big study, and it compared the change trends in New York and Pennsylvania before and after the introduction of report cards, and to the change trends in other states. So the other states outside of New York and Pennsylvania were considered the control states in this study. Specifically looked at the introduction of report cards related to CABG, as I said, coronary artery bypass graft, that's CABG. And the introduction of report cards led to a substantial shift in the incidence of intensive cardiac treatment. So what they found was that report cards led to an increased number of these procedures, of these CABG surgeries, performed in New York and Pennsylvania. And what they found is that the physicians were opting to perform the CABG surgery on healthier patients who are more likely to have positive outcomes. So this goes back to report cards cause so much competition and so much stress to do well that physicians were starting to do these surgeries on healthier patients who may not have needed the surgery, but who were going to have positive outcomes that these physicians could report. So the co-author of the studies gave one example. He said, quote, "One possible explanation is that operating on healthier patients is a way of boosting your report card score." So this was kind of a landmark study that says, okay, all of this data is great, but it's creating a competitive environment amongst physicians and hospitals and insurance companies. And so what they found in this study is that the report cards actually led to higher expenses overall due to an increased number of CABG surgeries performed and increased readmit rates for the sick patients. So it wasn't all that it was cracked up to be. I mean, this was, like I said, one of the landmark studies that was done early on. And what happened then is this data then started to decrease the number of CABG procedures, because once it was reported and they made these assumptions or made these, determinations that the physicians were kind of gaming the system, that healthier patients were getting the surgery and sick patients weren't having positive outcomes, it's actually decreased the number of CABG procedures that are being done in this day. Part of that is, of course, due to new technology, that no longer do they do the bypass grafts, that they have newer and improved equipment and technology. It's also based upon the quality management processes that have been implemented at hospitals that used to do CABG procedures, and finding out that the patient outcomes were not what was expected. And also, it's due to the fact that we are collecting more and more data on these types of high-risk patients and trying to make good decisions and change policies and procedures and treatment modalities based upon the outcomes that we're now seeing. So it's just one example of how they really looked at the impact of report cards and used the other states outside of New York and Philadelphia or Pennsylvania as the control, and it was just a really interesting study. So another type of report card is the internal organization report cards, and these you might be hearing a lot about dashboard reports. So this is done within an organization, and a dashboard report is a report to senior management that provides a quick, at-a-glance perspective on the current status of a project, but it's based upon predetermined metrics for that project. Depending on the organization, those metrics may include cost, time, requirements, risk, customer satisfaction, or other measures that are critical to the management team. So within any organization, based upon your TQM program, you're going to develop then metrics that you're looking at to know whether you're doing a good job. It's just like in your Brandman classes, you've got the syllabus, you've got the rubric, so that you know what it takes in order for you to do a good job. You've got the appendixes within your syllabus that explains exactly what is required for you to submit a paper or for you to do a discussion board. So that's kind of a rubric is a little bit of a dashboard report so that you as students know exactly what the metrics are. It also provides management with a quick understanding of the current project posture, in other words, where the current project is at, without a detailed explanation of the causes or solutions. So it really is a report card. It's like just a quick determination of what's going on with a project or a process. So why do you use dashboards instead of just reports? I mean, we've been doing reports for things for years. But what are the main differences between a report and a dashboard? Well, a dashboard is really meant to be short and concise. It's usually a one-page picture of what's going on with a project or a policy or a process that's being looked at. Reports can be short, but they're often usually longer in nature because they've got an introductory paragraph, they've got the supporting data, they've got a conclusion, and so it's more of a narrative rather than a picture. And there again, dashboards are visual. And even though reports can have graphs and tables and things incorporated them, it's usually just one aspect of the whole narrative report. Also, dashboards focus on specific measures, those predetermined metrics that are going to be looked at. And reports have a tendency to include more background and data. Another thing that's different is that dashboards are meant to be monitored at a glance. As I said, that one-page overview that you can do a quick look, a senior manager can do a quick look and know exactly whether he or she is on track or not, or whether their team is on track or not. Reports usually require more in-depth attention. In other words, they require reading through the whole thing and then making determinations. Dashboards also communicate specifics, so specific metrics that are predetermined. Reports kind of often tell more of a story. Reports can include dashboard reports such as tables and graphs, but they're, as I said, usually longer and more involved. Dashboards cannot, or at least should not, include a true report. In other words, there's not a lot of narrative in a dashboard. Dashboards are simple, and reports tend to be more complex, and dashboards are actionable. In other words, they have specific metrics that are being measured, and if you're not meeting them, then you should take action to improve them. So dashboards are often done on a quarterly basis for big organizations, or sometimes if you're looking at something very specifically, you might even do it on a monthly basis. It depends how you're collecting your data and how quickly you can turn your data around to be included on a dashboard. So an example of a dashboard, and I know it's not very clear, but you can see that this is a one-page report that includes a pie chart It includes 2 types of bar graphs. It includes kind of a thermometer or a speedometer type of graph. And so it's just a series. This is it. It's 4 quadrants that are very colorful, very quick to be able to review and compare them to the metrics that you've established for that project. So it is a very quick, visual, colorful type of report. And I've shared with you my organization, Access OC's dashboard. We do a dashboard report, and I wasn't able to download it on the PowerPoint because it's done in Excel, so it didn't transfer over to a PowerPoint. But our dashboard report is based upon our goals and outcomes that we establish every year in our strategic plan. So our dashboard report, and it's the group of metrics on our dashboard, changes on an annual basis based upon our strategic plan that we do in January. We report it out on a quarterly basis, and part of that is just because that seems like a natural report that we give to the board looking at a quarterly basis. Also, we don't have a lot of resources that can collect data more frequently than that. It requires data collection from each one of the team members, because I have team members that are responsible for different programs. So each team member, as they develop, or as we together develop their goals for the year, their goals relate back to the strategic plan and the metrics that we're going to be measuring on our dashboard report. As I mentioned, our dashboard is updated annually when our strategic plan is revised, and it is a management tool for performance. It's a tool for me to look at how well we're doing, but then I also have to take that to my board of directors and report off to them how well we're doing. So of course, I'm motivated to help my team members make sure that they're achieving their goals, because then the team members can see their results, and also the board of directors for the organization can see their results. And our Access OC dashboard is really very, very simple. It's based on the stoplight effect of red, yellow, and green. So you'll see when you look at it that it's very simple, and it's got the visual red, yellow, and green for each one of our metrics. I have uploaded an example of the second quarter 2011 dashboard report. So you can find it under week 7, under the week 7 tab, under weeks in the Blackboard for this course for quality management. So I hope you'll all go there and check it out and see an example of a dashboard report. You'll also see that we're not meeting all of our goals, so it's very realistic back there in 2011. And it's changed. In 2012 it changed, and then again in 2013 we just revised our strategic plan, and therefore our dashboard report will change also. So thank you so much for joining or listening to this lecture, and I hope it's provided some new information or additional information to your readings for week 7, and I'll look forward to reading your discussion board on checklist and looking at your comparison that you're going to be doing between 2 hospitals in your own community. Thank you.